Namaste everyone, I'm Dr. Rupesh Karn and I'm back with the second episode of the Medical Detective series. Today's case starts with a very common complaint. A 65-year-old woman could not sleep for 3 nights. Then her hands started shaking. At first glance, this sounds like anxiety, insomnia, thyroid disease, essential tremor, or maybe a metabolic problem. But as we go step by step, we'll see that the most important clue was not in the laboratory, not in the ECG, and not in the brain. It was hidden somewhere else. Let us begin. So before I reveal the diagnosis, I want you to approach this case like the admitting physician. There are 3 rules. First, do not assume a psychiatric diagnosis too early. Second, do not order everything at once. Third, keep asking one powerful question: what changed recently? That question becomes the key to this case. The clinical trap here is that the symptoms look common, the vitals look reassuring, and the key clue is very easy to miss. So the patient arrives. A 65-year-old woman was brought to the emergency department by her family. On day 1, she could not sleep. On day 2, her hands started shaking while holding a cup. On day 3, buttoning clothes became difficult, and she was brought to the emergency department. The family's first sentence was, "She is not herself today. She has not slept for 3 nights." So her chief complaints were complete insomnia for 3 nights, shaking of hands during activity, difficulty buttoning clothes, and a feeling of uneasiness, exhaustion, and worry. Let us look at the timeline. During day 1 and day 2, her sleep reduced to almost zero. Initially, no clear trigger was identified. She developed a fine tremor while holding objects. There was no clear confusion reported at home. By day 3, she was restless, mostly from exhaustion. Buttoning clothes became difficult. The family brought her to the hospital. There was no seizure and no loss of consciousness. So the syndrome is acute insomnia, action tremor, and difficulty with fine motor tasks. So now we come to the targeted history. There was no fever, no headache, no focal weakness, no hallucinations, no diarrhea, no alcohol withdrawal, no weight loss, no heat intolerance, no palpitations, no neck swelling, no eye prominence, and no previous tremor. So from history alone, CNS infection, stroke, alcohol withdrawal, thyrotoxicosis, and chronic tremor syndromes begin to look less likely. So she had hypertension and dyspeptic symptoms with aspiratory evaluation recently. She was independent in daily activities. There was no previous movement disorder. She was already taking duloxetine before this event for neuropathic pain. So she was not taking lithium, valproate, antipsychotics, or excessive bronchodilators. Now let us build the differential diagnosis honestly. At this point, the most common diagnosis should come first. Number 1, hyperthyroidism or thyrotoxicosis. Then comes anxiety or panic disorder, essential tremor, Parkinson's disease, metabolic disturbance, delirium or CNS pathology, and lastly, drug effect. On examination, her blood pressure was 134/78, pulse was 86 per minute, temperature was 36.8 degrees Celsius, oxygen saturation was 98%, respiratory rate was 16 per minute. There was no dehydration, pallor, icterus, edema, or lymphadenopathy. Mental status was also reassuring. She was alert, oriented, cooperative, and there was no bedside delirium or hallucination. So severe infection, hypoxia, sepsis, and major encephalopathy becomes less likely. Now we'll look for systemic clues. On thyroid examination, there was no goiter, no eye signs, no warm moist skin, and no brisk reflexes. Cardiorespiratory examination was also reassuring. Pulse was regular, there was no murmur. Chest was clear, there was no hypoxia. Abdomen was soft and non-tender with no organomegaly. So this slide is important because it gives us negative findings that reduce the likelihood of thyrotoxicosis and systemic illness. Coming to the neurological examination, tone was normal, power was 5/5 in all limbs, reflexes were not exaggerated, plantars were flexor, there was no rigidity and no bradykinesia, the tremor was fine, bilateral and axon related, it was prominent while holding a cup, and it affected writing. There was no resting tremor, there was no dysmetria or ataxia, so this does not look like classical Parkinson's disease, and it does not look like a cerebellar syndrome. So what can we already make less likely now? Now we can start narrowing the differential. Parkinson's disease is less likely because there is no rest tremor, rigidity or bradykinesia. Cerebellar disease is less likely because there is no dysmetria, ataxia or nystagmus. CNS infection is less likely because he is afebrile, has no meningism, and has no altered consciousness. Thyrotoxicosis is less likely because there are no thyroid signs and the pulse is not high. Serotonin syndrome is less likely because there is no clonus, no hyperreflexia. So we have not diagnosed yet. So we are just narrowing our differentials at this point. So now we order investigations. The purpose is to test differentials. So we check random glucose, sodium, potassium, calcium and magnesium, renal function and liver function, TSS and free T4, ECG with QT interval and rhythm, CBC and CRP. Neuroimaging is planned only if there are red flags such as focal neurological deficit, seizure, severe headache, altered consciousness or cerebellar signs, and our patient did not have any of this. So we deferred neuroimaging at this point. So talking about the lab results, hemoglobin was 13.1, WBC was 7400, platelets 2,46,000, glucose was 112, sodium 138, potassium 4.1, calcium was 9.2 and magnesium 1.9. So essentially all these values are normal. So there was no hypoglycemia, no sodium abnormality, no calcium abnormality, no magnesium abnormality that could explain the tremors and sleeplessness that the patient was having. So talking about other results, ECG showed sinus rhythm, QT was not prolonged, there was no arrhythmia, TFT was not suggestive of thyrotoxicosis. So at this point there is no clear endocrine cause, no metabolic trigger and no red flag for urgent brain imaging. So the common explanations are disappearing, but the diagnosis is still hidden. So this is the turning point. The easy answers are disappearing. The examination does not fit Parkinson's disease, cerebellar disease, thyrotoxicosis infection, or classic serotonin syndrome. The labs are not explaining the symptoms. So before ordering more tests, one question remains. Has anything changed recently? This is one of the most powerful questions in medicine. So what history is still incomplete? So we asked again, any new medicine, any over-the-counter tablets, any recent prescription? And she said that she had been taking prescription for stomach infection. So the prescription was reviewed. Drug 1 was amoxicillin. Drug 2 was vonoprazan. Drug 3 was clarithromycin. And now the timeline becomes extremely important. The symptoms started within 72 hours of this new regimen, and this is the moment when the case changes completely. What looked like a common complaint may actually be a medication-related syndrome. Now the differential changes. The most likely diagnosis becomes clarithromycin-associated neuropsychiatric toxicity. An akathisia-like reaction is also considered. Serotonin syndrome is considered, but it is less likely. Parkinson's disease, essential tremor, thyrotoxicosis, and metabolic causes become unlikely based on history, examination, investigations, and timeline. Now it is appropriate to place drug toxicity first, because the case has earned that conclusion. So probable best diagnosis now is probable clarithromycin-associated neuropsychiatric toxicity presenting as insomnia, uneasiness or restlessness, and bilateral action tremor. The word probable is important. This is a clinical diagnosis. It is supported by 3 findings. First, there is time relationship. Second, exclusion of common mimics. And third, improvement after withdrawal. So we are not claiming absolute proof, because rechallenge was neither ethical nor necessary. Now the major question is, why did clarithromycin become the leading suspect? Clarithromycin has reported CNS adverse patterns. These include insomnia, anxiety-like or agitation-like symptoms, confusion, delirium, hallucinations, psychosis in reports, and akathisia-like presentations. Antibiotic-induced neuropsychiatric toxicity is uncommon, but clarithromycin has one of the stronger reported associations among antibiotics in the literature. There are also published case reports of clarithromycin-associated akathisia resolving after withdrawal. In this patient, the onset within days, older age, absence of metabolic or endocrine explanation, and improvement after stopping the regimen made clarithromycin the leading suspect. Now let us discuss the other drugs. Why the other drugs were less likely? Amoxicillin commonly causes GI adverse events or adverse effects, rash or allergy-related issues. CNS toxicity is uncommon at usual doses, and there were no allergy features in this patient. Vonoprazan was not the classic CNS culprit in this presentation. However, it still matters because it was a part of the combination regimen and may influence drug exposure or tolerability. Duloxetine was already being taken before this event, so it can cause tremor or insomnia, but the timing pointed to the newly started regimen rather than the duloxetine alone. So duloxetine may have confused the picture. It was not the main new trigger. Another question is why this was not labeled serotonin syndrome. Serotonin syndrome was considered because the patient was taking duloxetine and had tremors and restlessness, but the key features were absent. You can refer to the Hunter criteria for serotonin syndrome. In this patient, there was no clonus, there was no hyperreflexia, no hyperthermia, no diaphoresis, or marked autonomic instability. There was no diarrhea. So Hunter serotonin toxicity criteria emphasizes clonus, hyperreflexia, hypotonia with fever, and autonomic features in the appropriate clinical settings. So we monitored her carefully, but clinically there was not classic serotonin syndrome in this patient. Now let us reason through the interaction. Clarithromycin itself has reported CNS effects. It is a CYP3A inhibitor. Vonoprazan is used as a part of H. pylori eradication therapy with amoxicillin and can be also used in combination regimens that include clarithromycin. Duloxetine is different. Duloxetine is mainly metabolized by CYP1A2 and CYP2D6. So this is not mainly a CYP3A explanation. The concern with duloxetine There is clinical overlap or additive CNS symptoms, insomnia, tremor, and restlessness, rather than a simple pharmacokinetic interaction. The practical message is this: in older patients, the whole medication environment matters. So our management was practical. We stopped the aspiratory regimen immediately. Second, we admitted her for observation and neurological monitoring. Third, we checked metabolic, endocrine, and cardiac mimics. Fourth, once she improved, we avoided unnecessary escalation. So why did we stop all the new eradication drugs initially? Because the patient was symptomatic. The culprit was not certain at presentation, and D-challenge was diagnostically useful. So after stopping the drugs, the clinical course supported the diagnosis. At 0 hours, the drugs were withheld. By 24 hours, sleep improved. By 48 hours, tremor and uneasiness were better. At discharge, she was stable and she was counseled about her condition. So improvement after withdrawal does not prove causality with absolute certainty, but in this clinical context, it is strongly supported on medication-related syndrome. So the next challenge that we had was treating H. pylori safely now. So the case does not end after stopping clarithromycin. The patient still needed H. pylori eradication therapy. However, after this event, clarithromycin rechallenge was not acceptable. So the next question was, how do we treat H. pylori safely in a frail, older patient? The priority was to use a clarithromycin-free regimen that she could actually tolerate. So what we planned instead was vonoprazan 20 mg BD plus amoxicillin 1 gram BD for 14 days. So why twice daily amoxicillin was used in this patient when there are regimens with TDS dosing? So we chose BD dosing because he was elderly and frail. There was concern for tolerability. There was concern for diarrhea. There was concern for non-adherence. And the schedule was simpler. So this was a shared, patient-centered clinical decision. So now we must also look at the literature, because there are we reviewed the literature before we started this regimen. So vonoprazan plus amoxicillin dual therapy has published evidence as first-line H. pylori treatment approach. A 2024 RCT evaluated vonoprazan and amoxicillin dual therapy for 14 days as first-line treatment. Another 2024 study specifically evaluated different amoxicillin administration regimens and vonoprazan amoxicillin dual therapy, including twice daily dosing approaches. A systematic review evidence also supports vonoprazan amoxicillin dual therapy as a valid first-line strategy, though regimen choice should still consider local practice resistance patterns, patient factors, and drug availability. So for this patient, BD dosing was not presented as a universal rule. It was selected because tolerability and adherence were major concerns. So the follow-up plan that we made was simple. We plan to complete the alternative regimen if tolerated. We plan to avoid clarithromycin in the future unless there was a strong specialist reason. We also plan to test for eradication at least 4 weeks after antibiotics, and we plan to hold the acid suppression before stool antigen or urea blood testing according to local protocol. So now let us summarize how the diagnosis unfolded. The patient presented with insomnia and hand tremor. Common causes were considered first. History examination and labs did not fit the usual explanations. The medication history was completed. Clarithromycin was identified. Symptoms improved after withdrawal. This is why medication history belongs early in every neurological or neuropsychiatric presentation. These are the take-home messages. First, do not label new insomnia and tremor as anxiety too early. Second, rule out common mimics with focused history examination and basic tests. Third, clarithromycin can rarely cause neuropsychiatric toxicity. Fourth, fluoxetine overlap can confuse the picture, but this was not classic serotonin syndrome. Fifth, in frail patients, tolerability may justify a simpler clarithromycin-free plan. So, the most important clue was not in the laboratory, it was hidden in the medication chart. Thank you. These are the references. Thanks for watching.